Hello and a very warm welcome to this episode of PHEMcast UEA. My name's Lawrence Hill and I'm one of the lecturing team at the University of East Anglia, delivering these PHEM modules in collaboration with East Anglian Air Ambulance.
Hi, and I'm Dr. Rob Major. I'm the Deputy Medical Director at the East Anglian Air Ambulance, and I co-host these podcasts with Lawrence.
Indeed, and on this episode of PHEMcast UEA, we are talking about international approaches to PHEM. All of the podcasts in this series form part of the curriculum, which is informed by the IBT PHEM curriculum, and this makes up these two modules specialising in PHEM. So, we'd love to hear what you make of the episode. For the students that are on the programme, please do leave us a comment and get in touch with us if there's anything you want to discuss. Today, we are joined by Dr. Maria Kratz. Maria, thank you so much for joining us. Could you maybe tell us a little bit about yourself and your professional background and what you do?
Thank you, Lawrence and Rob, and really great to be here. I'm a senior consultant in PHEM in Finland, in the area of Pirkanmaa, Tampere, which is in the sort of southern part of the Finland. And I worked in PHEM with PHEMs for about 10 years. And my background training is in anesthesia and intensive care, but obviously mostly in the past few years in PHEM. And also in addition to the clinical work, I'm a training lead with our PHEM service and then do some of the ACRM training for PHEM's crews.
And as a result, I think we'll be seeing some of the students later on in the programme. With any luck, hopefully we'll get to see you later on.
Absolutely.
Yeah, great. So thank you so much for that introduction. I think that's really helpful just to sort of situate who you are and where you are. And of course, in this episode, it's particularly relevant because we're talking about international approaches to PHEM and how and why this is relevant to students on the programme. There's some learning outcomes that are underpinning this session today. And Rob, if you'd like to take those away.
Yeah, so this particular session, the learning objective is to contrast EMS systems in developed and developing nations. And along with the other podcast in this particular series with Henry, you'll be able to see that and contrast these two very different systems of EMS and PHEM across the international space. So
yeah, absolutely.
Really excited for that.
Yeah, definitely. And the underpinning module learning outcome that's underpinning the session today is to contrast and critique the components of differing regional, national and international models of EMS systems. So could not think of a better guest in Maria than helping us to explore this topic. So we better get into it. What questions have we got?
Yeah, so we're just going to talk about your experience really, Maria, in PHEM, because we were lucky enough for you to come and work with us in the UK on EAAA. You came and did a job with us, and obviously your background is in PHEM in Finland and PHEMs. So forgetting the UK system, what is PHEM like? How does the PHEM system and what do you do on a HEM service in Finland? So what's a typical picture of a day shift or a PHEM HEMS shift in Finland?
First, I think there's quite a lot that's quite similar, but obviously first comes to mind if I start from the EMS, it's slightly simpler, I think. It is all of EMS in Finland is organized as a part of specialized medical healthcare, which means that all of the HEMS and EMS and emergency departments and ITUs work more closely maybe together on policies and SOPs and local guidelines and that sort of stuff. We don't have as many paramedic grades. It's just basically first response, which can be delivered by a rescue or police or border guard boats or that sort of stuff. And then we have mainly two paramedic grades, like really basic level, closer to your technician, and then more of a like advanced paramedic, and there's nothing in between. And then on top of that, there are field managers, which are sort of like LOMs. And then
like operations managers type thing.
Yeah, medical operations managers, or each service, police and rescue and EMS will have their own. And then on top of that, we have level 3 teams, which are all government funded in Finland. So all of EMS is. And this is also as a part of the specialized medical healthcare, so under all the same places like ITUs and EDs and that sort of stuff. And obviously FinHEMS, which is a government service, so all of them are organized by the same flight operator and provided by the same sort of helicopters and RRVs and managed that. But then doctors within that system are provided by each hospital district or well-being area, as it now is changing the vocabulary a little bit in Finland as well. So, but yeah, so that's sort of to describe the system a little bit. But then you asked, how is our day or shift, or how is the working as a HEMS physician different? So I think overall the tasking is slightly different. The use of tetranet radio and electronic systems and PRFs is to be honest, a little bit more advanced, I think, or it affects it quite a lot, how we do it. Cellular networks are superb in Finland compared to UK, so it makes it easier. And then, which means that the level 3 team, so the jobs are mainly sort of the same. So you have a collection of medical and trauma and everything in between. As you know, you can get something quite unconscious patients and TBIs and CPR and that sort of those are like the big bulk of it and the trauma. Mm-hmm. But then you can have really everything in between what you can think of. But to find where I was going, I think so the jobs are pretty much the same, but the system works slightly different. So we can stay in contact with the medical crews while they're heading to the job, and we can get more information on while we're on our way to the scene, which makes it a lot easier to plan or pre-plan or form a situational awareness between all of the crews on ground and in the helicopter or in the RRV if you're using that. And I think that is a really big difference. And because of the tasking, we don't as of yet have HEMS dispatchers, and most of the tasking comes directly to us. So that means that it's not always as efficient as in UK, but we get a little bit more stand downs and that sort of stuff. But then we're there more early on these TBIs and right. And so I think that's something that I struggled with a little bit with the UK system, because quite a lot of it is crew request, which is not to say anything to the crews, but just the system is different. So then that produces a delay for the level 3 team to get there. But I think then what the electronic, the tetranet radios that everyone on the job in question, whether it's border guard or rescue or police or social services or whatever, all of us can find a joint radio channel to directly talk to each other. And with the electronic systems, we can already get quite a lot of information, who's already on scene and who's not, and how are the patient's vitals and that sort of stuff. So we can pre-plan quite a lot, and then you can at its best, you can then do the job more fast and in a more you don't have to do as much organizing the team on scene. So that's what I'm trying to say. So everyone can do their bit, and I think that's one of the biggest difference in my view from the services that I've had the pleasure to work with.
Sure. And how much of that do you think is due to this difference of being like FinHEMS being government funded and it all kind of leading? It seems to me that is a significant part of the difference here between Finnish model and a UK model of HEMS. Is that fair to say, Rob?
Yeah, well, I mean, we debate this a lot. I think there are some real benefits of being not government funded because you're not constrained.
Yeah.
And we can innovate and do things quickly. Whereas I think, I mean, Maria will be able to comment in a minute. I think when you're government funded, that money comes with constraints. But it does sound like, and I've not been to Finland, but it does sound like the system is much more well integrated because it is a government system and everyone works together. And we'll speak to Maria in a minute about it. But I know that Maria and the team spend a lot of time sort of giving remote advice to crews as well, which we don't do so much on our service.
Right. So and that relates to that fact that you are so much better connected through the radio and the mobile data network that you can have that closer integration with the road crews.
So yeah, I think that's exactly that. So first, I want to kind of say what Rob was saying about the government and not government funded. So I completely agree. If you have a HEMS service which is well funded, obviously you'll have more funds and you can be quite more nimble in applying new or trying out new things and seeing where that goes. But I think also, even if I say that we are government funded, so that means that our government provides the helicopters and RRVs and pays for the pilots and HEMS crew members who are HEMS technicians and paramedics at the same time. So we have a 3-person crew, single pilot, we want to be there, that we are really trying to standardize and be similar in each part of the country. But I don't think we are as much as you think, because then each of the hospital district or well-being area, they decide what sort of resources they give to the PHEM unit in question or HEMS unit. So that would mean that, for example, for the service that I work with, they see it as a really vital part, and we have quite good resources, so quite many senior consultants who can then, in addition to the clinical work, do this development and research and development work as well. But there are services who don't really have that many positions for R&D positions, and it's mostly then clinical work, and that's sort of like a local position. So then obviously that will result in a more, so they're not completely
There's more
homogenic.
variability.
That's what I'm saying. Yeah.
Sure.
So we see at the same things, that some services sort of have better resources and some don't. But at its best, I think where we're headed, it's gonna be, it is a good system, I think. Yes.
Great.
But I'm sorry, you asked then about the. Sorry, Lawrence had another question about the.
It was I made a comment about, because I know we've discussed this before, about when certainly at EAAA, when we're not on a job, we're doing training or we're doing our own thing, but we don't provide anything else for the wider ambulance service. We don't, we're not there as a resource for them to speak to when we're not actually going to a job. But I think that's slightly different in Finland, isn't it? So you can actually give advice to crews and not deploy. So you can tell them, give them some advice, and then stay on base because of your ability to do that in a bit more joined up technological way.
So yeah, that's true. We do sort of like level 3 team telemedicine. So I think
Wow.
I think sort of some of your HEMS dispatchers sort of do this advice a little bit, or then you have other professionals who do remote decision making relating limiting patient care, PLE, and that sort of stuff. But or non-conveyance. But non-conveyance is a really, really big part of the Scandi PHEM system. So approximately 1/3 of all of the patients that the MS sees is not conveyed, and it's also growing a little bit, and it's not just to go in there and do an evaluation, but they will have more point of care laboratory sort of stuff, or some they will bring, and they will try and develop those with social services, and so to try and bring the remote services via the EMS at the same time. And obviously that needs then physicians to sort of give that, So the electronic PRF systems that we are developing nationwide, the video consultations, so you can actually see the patient, and also then not as patient care, but then you can use like video diffusing if you have these really difficult jobs and you're remote, and because the HEMS team doesn't always get to take part in those if you have to return to base or something. So I think in that sort of sense, yes, that comes into the day quite more, and
is that, sorry,
yeah,
video diffusing? Do you mean what do you mean by diffusing? Is that like debriefing, like taking
so
part in
like,
unpacking the incident?
Yeah. Meaning like a really, I don't know, kids CPR, a really big trauma job, and if you don't have the time to stay on scene, you take the patient to the hospital and have to come back to base. But then if there's a diffusing or debrief for the crews, you can in some areas we've tried to take part in those via Teams or Zoom or that sort of stuff.
That just
it's not
sounds incredible.
It's not optimal, but it's better than nothing, I think.
Mm.
At least for the teams on location, because then they can get the level 3 team to take part in that. So I think
so important, I think, for learning as well. I mean, speaking as someone who was, fairly bog standard road paramedic, before I came into higher education, having that opportunity for a bit of debrief and a bit of closure is so useful, and to have that opportunity for supervision and to do some learning after the event is, I suppose that's facilitated by this great mobile data network that you're talking about. But I can imagine that would make a big difference in the UK to the kind of working lives of paramedics.
Yeah, I mean, we try really hard on really big jobs. We D&D all the cases. It's very similar in terms of the big cases. We'll do that remotely. We'll debrief our teams and we'll have a case review process. But it's really difficult to get the ambulance service clinicians involved with that. And it's normally remote in time as well. So it's quite a long period of time to get all the right people in the right places, shift patterns and everything. So if we were able to, an hour or two after everyone had gone back from the job, because Maria's right, you don't have time to do it on scene all the time, to be able to dial them up and say, should we have a quick, half an hour chat about that job, a welfare check, and have all the clinicians dial into a single point, that would be really good. But it just, we don't have, part of it is the different organizations don't have that agreement. It's that how you would do that. It's the technology. It's finding time in their day. The paramedics will just be straight onto the next job.
Yeah, of course.
So it's protecting all that. And I'm very jealous of a system in Finland that seems like, I'm sure it has its down points as well, but is much more mature and connected in that way. Yeah.
Sounds interesting.
I don't think it's quite there yet, but there are elements that are quite good. And I think one of the things that like the level 3 team telemedicine I described, I'm not saying that's not happening in UK, but it's not happening by the HEMS team. And it obviously sometimes when you have a really busy day with a lot of really difficult jobs, I think then the downside is that if you have to do a lot of telemedicine on the same 24 or 12-hour shift, you're quite tired and you have decision fatigue, and you have to kind of think that, am I able to do all of this? So it's not optimal. But the good thing about it is that if you actually are the one who's giving advice to or support to the medical crews on scene, to the EMS, then you are really more connected than with the UK HEMS team, I think, in sort of way. So it's quite a low threshold for the teams to then, after the job, to call me and to have an informal debriefing on the job, or just to chat or ask that sort of stuff. And obviously that happens in UK as well, when people know each other, and the paramedics who come into PHEM to work there for a year or 2 or 3 years or something like that. So obviously that happens, but maybe not so much that they would call directly to the physician. So in that sense, I personally, I enjoy having that connection with the crews as well, and also feel that that's quite an important part of my job as a physician, that I feel that I can do additional good, not just the PHEM jobs, which are obviously
Sure.
that as well. But but I think this is also, maybe some people will view it a little bit differently. So I don't think there's an optimal one choice or one answer, one size fits all, but these are some things that I kind of feel about that.
No, that's great.
And one of the really interesting things is obviously it's quite a different system. Many things are really similar to what we do, and there are some key differences. But I'm sure for the training, you know that we do when clinicians come into our service, we do a PHEM course. And we train them all to a certain level, and then maybe 1 or 2 weeks of quite intensive training, and then they'll do some on-the-job training. Is the training in Finland for new clinicians coming into the service the same? How do you? I know you're an educator as well as a PHEM clinician. How do you train new people? How do you do that? And how do you? How do you train them to do the remote stuff as well, or is that just because you've always been doing it in your day job that just sort of comes naturally? Is that something you train for, or?
So the system is slightly different in that most people who will come into, because let's face it, Finland is 1/3 bigger than UK as a country physically, but then we have 5.5 million people, and you have like 68. So we don't have as many PHEM units and as many positions as you guys, so there aren't as many new doctors coming in and going out. So the systems is slightly different. So yes, every year someone will come, or every 6 months someone will come, but it's usually only one person at a time. So in that sense, we don't really have the possibility, or at least so far, to have that sort of a course. So obviously then it makes more sense for us to do it as an on the job training, so to speak. So first couple of weeks they'll come in and they'll be more of an observer for our teams, and then the training physician will go over certain stuff, and we'll do simulations on the shifts as well, and there are some so there is a curriculum that we follow, but also it gives more of it gives a better way to then directly from day one to integrate them to the service, because some will have some experience from outside the hospital, from PHEM, if they worked previously as a paramedic, like some doctors have, but then some will know nothing, and like giving them the Tetranet radio, which will have hundreds of different channels, like I described, because you can talk to everyone in different. So sometimes it's the technical bits can be really, really difficult then to integrate to all of the medicine that needs to be checked, that they know of and are familiar with our standardized methods and SOPs and guidelines within our service, but then also to how they then handle all of the CRM and the crew and everything. So so in that sense, yes, there are similarities, but then because of the system is slightly different, then also that's why it is a slightly different training program.
And the curriculum you mentioned, Maria, I know you guys do a lot of training. Is that a curriculum that you've that is sort of shared amongst different PHEM services, and is it standardized, or is it something that is fairly individual to the service? Or I mean, we have sort of a national PHEM curriculum that this is based on. Do you have it? Is that curriculum that you teach your paramedics to standardized across Finland, or is it very specific?
So yes and no. So a couple of years ago, FinHEMS actually did a HEMS standard, which would mean how people who come in medically, how they're trained, or what's the minimum, and also what's the minimum amount of shifts that you should do per year, or the frequency of them, or how many patients would you aim to see during the year, so it's not just shifts that you never see anyone. And if that's not met, how do we then supply that with simulation training or that sort of stuff? But because of the resources, like different well-being areas, they're not willing to give all the resources that would need. We're not there yet, so that's not fully applied. And we're in the process of then, so some services, so in the southern part of Finland, that's what we have quite similar programs from what I know of, and I've worked in 4 of them, of the 5 ones that are in the south. And so it's a work in progress, but yes. So yes and no is my short answer.
So Rob, does that sound like the Finnish model is closer to a standardized model than a UK one?
Yeah, it's very. I think it's the PHEM systems all tend to be really complicated, and certainly in the UK, we have a PHEM curriculum, but a lot of PHEM clinicians don't work to that curriculum or aren't in training. So it's not like, if you go into emergency medicine practice or anaesthetic practice in the UK, you'll be trained to the Royal College of Anaesthetists or the Royal College of Emergency Medicine standard. PHEM, there is a curriculum, and we have a PHEM training program where people go into that and are trained to that curriculum. But we have loads of doctors who practice outside of hospital and paramedics who practice outside of hospital who don't have specific training that is linked to that curriculum. And the curriculum is supported by the GMC, so it is a subspecialty training program. But actually, PHEM is practiced by a whole load of different levels of clinicians. I mean, Maria's talked about the sort of 2 or 3 grades of paramedics they have. There are hundreds and hundreds of different grades and specialists and urgent versus critical, across the UK. So it's a much different piece. But I think the one thing that FinHEMS have been able to do is integrate some of probably integrated their HEMS service within their EMS system.
Certainly
they're
sounds
ahead
like
of.
that.
I think they're ahead of where we are. Yeah.
So I think one thing about our system is that actually the way we get the resources to have physicians in PHEM is that, for example, in our area, my main responsibilities in addition to clinical work are within the HEMS crews training, so training the HEMS crews. But actually most of the other doctors, their main responsibilities in addition to clinical work is actually developing the ambulance service in the area, or developing sort of like CBRNE or major disasters, or how we work with our border guard or our military and that sort of stuff. So in that sense, we are really much more integrated, because I see you have all of those great people who do that, but they're not, at least not all of them are in PHEM, and so so that is obviously that might mean that sometimes your job as a PHEM clinician is quite if you have a lot of those responsibilities, then you can't do that much other clinical work outside PHEM. And I think that's the risk in our service, that we have maybe a bit more clinical work than some of your PHEM physicians, but is that still enough to produce enough patient contacts, and how often should we go into the ITU or emergency department or anesthesia or whatever, different fields of specialities, to kind of refresh that sort of recurrent training.
Sure.
So I think everyone will struggle with that, but the benefit in our system is that then we can kind of develop both of them at the same time and hand in hand. And like you said, because we don't have as many different paramedic grades, or at least they're the same in all of our area, so it's possible to produce an anesthesia intubation protocol, for example, or a resuscitation protocol that's obviously will abide by the ALS guidelines and that sort of stuff, but you can build on top of them, and then you can just so it makes again, like all the CRM stuff, easier on the job.
Sure.
When you have pre-planned programs, you can just say, now we'll use this program or this, and then you can train them for the crews, and then again, if you get all the information while you're going on the job already, and you can kind of make the pre-decision, so then fastest you can do is like anesthesia intubation. You can use 10 minutes to do that, and that's still really, really safe, with a really good first pass success rate and few complications. So I think that's maybe something that Rob's talking about.
Yeah, absolutely. Yeah, it's that interaction with the, we go on behalf of the ambulance service, but we never quite know the crew who we're going to meet at the roadside, and they're very variable. There might be lots of them, and we might be first on scene, but we don't get any opportunity to say to them, you can work, we're coming, you can work outside of your normal guidelines, and you can prepare for this. So we have to do quite a lot of that prep work, and we have to be able to function as a crew just on top of standard paramedic practice, where I think what Maria's talking about is they're able to do some of that joint training. They're able to empower some of their paramedics to prepare the patient quicker and better, so that when they do turn up, that process is a bit slicker.
Yeah.
And that's the benefit of working in a more integrated way. And some of that is numbers and geography and all of that stuff. The East of England ambulance service is massive. You could never train everyone to do that, and I think that's part of the challenge.
Great. Well, that's really interesting. So what do you think then? We've talked about a lot of the kind of the positives and a lot of the sort of strengths of the Scandi or the PHEM system. What do you think are the biggest challenges for you working within that system?
Well, like the geographical challenges, like that we have few big cities, but I don't think most countries in the world would even view those as big cities. But we have few of those. But then it's quite sparsely populated. So obviously then to try and deliver good quality care everywhere, and also that will mean for the EMS crews that even if we train them really well, some of them will work in an area where they hardly ever see big trauma or something, or like resuscitations or something. So the HEMS crews might, because they have such a big circle that they go into. But if you work in a only RRV, physician staffed RRV or let alone EMS in a really, really remote area, then that is a really challenge to sort of keep that recurrent training that they're sufficiently good. 2 seconds. Sarm. Al. Nine. Sorry, he found his bone, so I can't.
Oh, good.
Yeah.
Okay, yeah. So geography,
Okay.
I can imagine the geography is a major challenge, and I mean, the weather because it gets quite chilly, doesn't it, Finland?
Next week
Does
is
that
supposed
provide
to be
any specific?
-30 in all of the countries, so we'll be looking forward to that. So yeah, obviously the hypothermia is a huge risk all year round. It's not just the winter, but also the summer. So I think in that sense, for example, the 360 access, that is a really, really golden standard in UK PHEM, and actually quite worldwide maybe, with good quality systems. But in Scandinavia, that's just not safe for the patient. So
Sure.
it makes no sense if you've gotten the patients from the roadside, from an RTC to a warm ambulance, to then take that outside and then start stripping the patient and doing surgical procedures or anesthesia and giving that sort of stuff. So we work quite a lot, 99% of the time in the ambulance, unless we're obviously on scene at someone's home or something like that. So that's a big difference, and it's also a challenge. And obviously that comes, I'm not saying that it doesn't come without its risk. So that's one thing. But and maybe some of the challenges is, I'm trying to think of how I can put my words. I think we have because of the electronic systems, we have quite good statistics, and obviously we have patient quality groups and teams and some daily or weekly and quarterly reviews of all of that, and then that is to some extent used with planning all the training. I hope to develop that a bit more, but still. But then I think the Scandi systems might or at least Finnish system might learn some things from the UK governance, and or maybe both ways. And if I think about the clinical governance that I experienced within EAAA, I really enjoyed it. It was massive compared to what I've had in Finland, because we don't have the same sort of system. It's partly like a resource thing, maybe, but also a cultural thing. So we're not as used to having that. So I would want to see that is something that we look into more and improve it a little bit. But at the same time, then, because we do quite a lot of in the services that I work with the regular crew training every month or every other month, which involves, for example, regular simulation training, which provides us a little bit like we can do, like the aviation side does regular line checks for the HEMS crew members and pilots, and we're actually in the process of trying to do that for our doctors as well. So I think in that sense we get to review how the protocols that we've standardized, how they are then applied, that people are actually sticking to them. Because if you only apply them and give like an initial course and then you don't really review that, then we'll know that it's likely that that's not getting done as we've quite planned. So I think what I really like to see is more collaboration with maybe two of the different systems. I'm learning from each other's, because I think there are elements to both that are so I don't want to say that clinical governance in Finland is bad, but I think there's a lot we can do to improve it, and I think there are some minor elements that maybe we can learn from each other.
Great.
Yeah.
Oh, thank you very much.
Brilliant.
That's really interesting, and it feels like a good time to move into our kind of the final part of this this discussion today, Maria. So, every guest that comes on our Femcast UEA episodes, we're asking them to share like just a little insight or a little what we're calling a golden nugget, which has been important for you having a successful or a happy career in pre-hospital emergency medicine. So, if you were to share your little pearl of wisdom or little golden nugget with all of our learners on the program, what would that be?
That's a good question. I think I'm gonna try and be brief, but I want to say two things. For me, it's which is no surprise that I'm a training lead, but for me, I don't think if you want to do a long career in FEM, you need to also love the part of, like we just discussed, about the governance or improving yourself or trying to look at what can we do better. I'm not saying that we can ever reach a perfect HEM job and trying to be the best in the world. I don't think it's not about that, but it's trying to look into everything that you do, how we can do it better or how we can change it. And no training program and no service is ever ready. So I think that is something that if you learn to love that, then that will give you so much motivation and joy in the process. Because otherwise, if you only look at the successes of the job, you also have to kind of everyone who's done this job knows that the nature of the job is such that sometimes with the information we have, we can't really do always the best that we can. So then we have to think how we can then improve the circumstances or what can we do so that next time we can overcome this challenge or this and this and this. So I think that's what makes this so interesting, because that work never stops. But then I think my best nugget is that what sort of makes me a good FEM doctor or HEMS doctor or it's my team. Every time it's my team. So this is a job that you can't do by yourself. Obviously, you need to have the certain level of basics, skills and knowledge, and see that you are recurrent yourself and training and that sort of stuff. But it doesn't matter if your team isn't with you and you're not with the team and you don't do it together. So the FEM team is my golden nugget and secret.
Thank you. That is brilliant, actually, and like totally original as well. It's so nice to hear that.
Yeah, absolutely.
That actually your happiness and success in what you do emerges from the people around you and how you interact with them. That's lovely. Thank you so much.
Thank you, Maria.
It's been great talking with you. It's been really nice hearing your insights and getting that international perspective on pre-hospital emergency medicine. So before we say cheerio, we'll just recap the intended learning outcomes from this podcast, which are to contrast and critique component. There's a lot of C's in that. To contrast and critique the components of differing regional, national, and international models of EMS systems, and to, taken from the IBT FEM curriculum, to contrast EMS systems in developed and developing nations. We hope you've enjoyed listening to this episode. I'm sure you've learned a lot from it. And I'm sure you'll join us in saying a massive thank you to Maria Kratz, Dr. Maria Kratz. Thank you, Maria, so much for your time.
Thank you.
Thank you so much. Thank you.